3, 2, 1. We are live.
Okay.
Good evening, dear friends and colleagues. It's my proud privilege to have this evening meeting with all of you here and my dear faculty members, many of whom are my personal friends. And also, I would like to thank Dr. Tejendra Singh to be a part of this meeting and also be the convener for this meeting. And I hope that we keep conducting these meetings so that the interaction keeps continuing between all the oncology fraternity members. So the topic which we have come here today is updates in management of hormone positive, HER2 negative advanced breast cancer. So that was the topic with which we thought that we should actually discuss, because a lot of things have happened over the last 3 months, and it's been really difficult for us to connect in person. Though that I would have always loved that we would meet in person and would chat with each other, but then situation has made us to be this to be the new norm, and all of us meeting only over Zoom and trying to zoom our faces and put our brave front. And I also thank everybody for joining us here. And to set the ball rolling, I like to invite Dr. Tejendra Singh to proceed with the meetings further. Boss, Dr. Tejendra Singh.
Thanks, Dr. Sajjan. Good evening, everybody. In this program of HR positive breast cancer, as such, the advances are very fast in the oncology, in particularly in the breast cancer. So the today's agenda of discussion regarding the update in the management of HR positive advanced breast cancer, the faculty, first I would like to speak to call upon Dr. Vajpayee. He is the well-known oncologist of Delhi. He is HOD and consultant medical oncology at Manipal hospitals. So I will request Dr. Vajpayee kindly to take the topic. BRCA mutation in solid tumors.
Thank you, Dr. Tejendra, and thank you, Dr. Sajjan, for giving this opportunity. My topic is BRCA mutation testing in solid tumors. And can everybody see my slides? And am I clearly audible?
Yeah, proceed.
Yeah. So we know that BRCA testing actually gained a lot of momentum after this celebrity over here in this picture actually did the interventions, and a lot of queries then started happening world over. So I would just discuss these particular 8 points in my talk. So right from the basics, that what are these genes and rationale of testing them, and when should they be tested, how is it done, what is the ideal method of testing. I might not be able to really do justice with this particular point, and what is the role of somatic BRCA testing, how to interpret the test report, what is the importance of genetic counseling, and how to select the BRCA testing laboratory. So right away, what are these genes? So BRCA gene is it is a check on the DNA repair fidelity. So it checks that the DNA repair happens properly, the double-stranded breaks especially had happened properly. It forms a complex with the other molecules like RAD51, and it is a participant protein in making sure that the DNA repair the double-stranded breaks are repaired properly, and therefore the cell does not go into apoptosis. So also it is a cell regulator in terms of cell cycle arrest and also induction of cell death. So it regulates these two mechanisms as well. Overall, it provides a genomic stability, like the P53 this is also a sort of guardian of the genome. So where are these actually genes located? These are complex genes, the BRCA1 gene, which is located on chromosome 17, and the BRCA2 gene, which is on chromosome 13, the long arms. So these, as you can see, these are long genes, and these look complex in terms of their entire coding regions. There are intron and exon boundaries, and there could be large insertion and deletions up to 10%, 5 to 10% of them, which really require some special methodologies to check. So you cannot imagine to check this complex gene with simple a hotspot methodology, the hotspot way of checking mutations. Well, coming to why to actually check them, because they are known to cause these particular malignancies, and you can see the increased risk for those who actually are carrying them. So these behave in a dominant fashion. Even a single allele would actually see that the patient could become symptomatic for could manifest these many malignancies. So you have this in the chart. I won't go into the details of it. We already know that what are the incidences. What is important is knowing the classifications. Classifiers are the germline BRCA mutation, which is there in all the cells, right from the blood to the saliva and all the cells, because these are what we inherit. And then comes the somatic BRCA mutation, which is actually found only in the tumor tissue. After there has been two hit, or probably there is a heterozygous gene also. Then there is a tissue BRCA, and then tissue BRCA is actually, when we use this terminology, it is actually both we are trying to encompass that the germline and the somatic mutation. So the key message over here is BRCA genes are tumor suppressor gene, and they check on the DNA replication, the double-stranded breaks. They check that the replication takes place properly. Mutations in the BRCA1 and 2 gene can cause cells to become abnormal and grow in an uncontrolled way. BRCA2 mutations are also common in pancreatic cancer. So it's not just breast and ovary. We all know that pancreatic cancer and other malignancies are also associated with it. Mutation in BRCA genes could lead to increase in women's risk of both breast and ovarian cancer. That's what we know. What is the value of testing in ovarian cancer and breast cancer patients? Well, we know that we need to inform the patient about the prognosis, and then we need to plan the treatment, and then we need to inform about the risk in the extended family, that is identify the unaffected. So if we have to identify the unaffected relatives who harbor BRCA mutation, so the lifetime risk in the general population, as you can see, is 1.3%, but it is very high up to the age of 70 years in BRCA carriers. So in BRCA1, it is almost 39%, and it is almost 11% in BRCA2 for ovarian cancer. So that is why they should be tested. The carrier should be tested. Then what is the way the disease would behave? We all know that BRCA1 and 2, if they are present, the patient of ovarian cancer, invasive epithelial ovarian cancer, would usually behave better than otherwise. We can actually have an idea, although we can also get indirect reflections that if good platinum sensitivity is there, it could also be a BRCA1 and 2 mutation could also be there. So these patients usually respond well to platinum themselves, and we have seen good survivals with them relatively. So talking about the breast cancer, well, here the story is different with triple negative breast cancer being the odd one out, and most of the times they manifest as that, especially the BRCA one. However, they also are important in guiding us treatment, and this was one trial where they have helped us. Also, likewise, SOLO2 is one study where there was a significant benefit, as you can see in the PFS, by using this targeted therapy olaparib. So also, it's not just restricted to breast and ovary, it is also in pancreas, that if in case you are able to identify, and POLO study was done in such patients where the benefit of PFS was gained in pancreatic cancer patients. So the key message over here is that understanding of women's BRCA status can improve future management decisions. And then knowing a BRCA status can inform treatment decisions in ovarian, pancreatic cancer and may improve outcomes. For breast cancer survivors, BRCA mutation, the risk of subsequent gynecological cancers is high. The risk of BRCA testing in a lady with ovarian and breast cancer can help to identify family members at risk. When should the testing be done? Now, the testing should be done if in case we have a patient of ovarian cancer, most of the guidelines are in consensus that either it's a high grade epithelial carcinoma that we are dealing with, or endometrioid carcinoma. And also it's not just ovary, it is also the tubes and the peritoneal cancers, even in the absence of family history. So that is important. So the BRCA testing, how to go about it, if in case we are talking about the ovarian cancer patients. So if there is a ovarian cancer diagnosis, and now that we have data also in the maintenance, so it is good to refer for BRCA testing upfront, refer for BRCA testing. If in case there has been a chemotherapy given and there is a platinum sensitive relapse or otherwise a relapse, one should always consider testing for BRCA. And so also post second line chemotherapy, one can consider if in case it has been missed earlier. However, the flowchart is on the right side is very clear that a pre-genetic pre-testing counseling is very important, and it should be done by a trained personnel. Germline BRCA analysis is thereafter undertaken, and usual TAT is usually 3 to 4 weeks, and one can get these of the following results, which we will discuss further. So the key message is early testing. The early you test, the better it is in these days for ovarian cancer patients, and it's better to test at diagnosis. How is BRCA testing done, and what is the ideal method for testing? So now here is the question for translational research. 3 key elements for BRCA gene testing are there, and the first, you need to have the sample well collected, and then comes the library preparation and sequencing, and then you need to actually look into the data and interpret the results accordingly. So as I told that there are 2 methods. Either you look at the germline, and germline can be from every cell in the body, and most common either you look at from the blood test. So you can take that from the patient, or the if in case you're looking at the carriers, then you want to check for carriers, then relatives blood sample. For the patient, the tumor tissue would also be there, where you can actually look for both the germline as well as the somatic mutations. So this would be tissue BRCA as the terminology goes. And then once this sample is collected, now Sanger is sort of previous decade, and now we have these 2 machines, the NGS, where the library preparation and sequencing happens. And then once you have the data available in the sequencing done and the sequence alignment done, then you need to actually look for various variants. After having the sequence annotation done, you need to then have what sort of variant it is, and look at the database. So we know that there has been a shift, and most of us are also adopting it, that the Sanger sequencing is because of the time taken and the depth. So there has been a shift all over the world, and this is also there presented in ESMO, this particular data where there has been a shift towards NGS. And it is quite evident that because it is fast, and then you can have multiple BRCAness also as well as tested, and also it is cost efficient. Now, talking about this particular methodology, once you have a negative report and you are really sure that there is a strong family history, so you can look actually, and there is an ethnicity if you're looking at especially the Jew population, then you can actually look at this particular methodology, multiplex ligation dependent probe amplification, where you can actually catch nearly another 5% of mutations. So this is important. So comprehensive large rearrangement testing in conjunction with full gene sequencing is an appropriate strategy to check for clinical BRCA1 and 2 status. So talking about the turnaround test, now turnaround time is actually getting better, as we know that there was a time then it would take 6 to 8 weeks. Now it is getting lesser. And so the key message is that how to get this tested is majorly by NGS in today's date. It can identify BRCA1 and 2 and the variants. Hotspot mutation, as I told you, the gene, looking at the gene, a complex gene is not the way to go about it. Once you are sure that it is probably a genetic disease inheritance that you're looking at, and you find that there is no mutation detected, then you can look at MLPA, go back to the history and ask the lab for a reflex MLPA. The BRCA testing plays a role in clinical decision making. Thus, shorter time is important, and you should choose the lab accordingly. So, what is the role of somatic testing? Well, you might miss amount of percentage of patient if you are just looking at the germline. So somatic, as I told, is majorly found in the tumor tissue, might not be in the cells of the body. So this is why somatic, you need to look at the tumor tissue. And if you look at it, the germline and somatic mutation proportion in ovarian cancer, so you have approximately 40% more patients who might not have any family history, and you might catch these patients. So overall 5 to 7% extra on the whole population. Otherwise, a significant chunk that you could miss if you're not doing somatic. So just talking about some Indian data, which was presented by Dr. Sudeep sir, and overall germline BRCA1 and 2 prevalence and VUS in the Indian population at TMH, this was a multi-center data, sorry. So here they actually looked at the patients with BRCA1 and 2 mutation, and they found that nearly 21% were positive, and there were VUS was 4.2%. And they found that BRCA1 is the predominant mutation with 41 patients, and BRCA2 nearly half of the population. The sort of mutation was frame shift mutation, which was predominantly there, and then the second one was missense mutation. So this was actually, this is a comparative chart with the other, I think so RGCI data is also there, as we can see. Many of you must be knowing this. And here again, quite a similar reflection. Here it was 30% in breast and ovarian cancer patients. VUS, as we can see in the Dr. Sudeep sir's study, was around 4.2%. And what is important highlighted over here is that nearly 2/3 of the patient did not have any family history. So if in case you are just looking at the family history and testing for the patients, then you might be missing a significant chunk. So this is what is important. So we must also look at the somatic mutations also. So just to highlight that it's not just the breast and ovarian cancer, there are patients of pancreatic cancer also who have germline BRCA mutation, and then there are treatment pathways. They are really platinum sensitive. And apart from that, now with the availability of the target medicine, we must look at these mutations. Also, these patients should be in their relatives should be looked for the possibility of this should be included in their relatives once this question of having inheritance of breast and ovarian cancer arises. So how to go about it, whether you have a patient, and whether would you go for germline testing first or somatic testing first? Well, then there is this algorithm, and this is, as you can see, this is the MD Anderson protocol. If they actually checked on the BRCA1/2 mutation, where they checked from the, they went this way, that they checked on the germline test and they found if it is negative, and then they did the tumor test vis-a-vis doing the somatic mutation first. They found that the cost would be relatively saved, so also the time. Now they are looking at benefiting the patient actually in terms of giving a earlier report, and then they are looking at if there is positivity, they are then cutting short on doing extra germline mutations. So they are then they did this analysis and they found that you would probably save on cost. But the complexity is that somatic BRCA testing, to my knowledge so far, is actually a complex way, and most of us agree with this. And therefore, probably we need to still look at this algorithm with a pinch of salt. So interpretation and clinical reporting, talking about that, this is the five-tier system which one usually looks at, and this is from IARC, where the class 4 and 5 are actually, these are the positive ones where one should actually act. The class 3 is uncertain, or the VUS. So talking about the variant classification and what are the practices worldwide. So as you can see that 38% of US labs and 47% of non-US labs use ACMG guidelines for variant interpretation. And what is important is VUS rates for the labs are determined to be in the range of 3 to 50%. Also, reclassification of VUS translate to reduction of VUS rates. 57% of US labs reassess VUS at least once a year. In contrast, it's 9% of non-US labs. Majority of the US labs submit sequence variants to public databases. So this is important, that to reduce the VUS, submission of the various variants to the public database is important. And the most preferred public database is ClinVar. So the key message to take from this is how to go about testing and choosing a lab. Variant interpretation should be done by a recommended method like ACMG, and select labs with minimum VUS rates whenever possible. How to interpret a report, how to go about looking at the report, the quality of the report. So you have these various identifiers. You have the patient identifier and details over there, and then the lab details, and then the reason for referral should be clearly mentioned. Whatever the test findings are should be clearly mentioned in an unambiguous way. It should be mentioned. Well, the test details, how did you go about it, how did you go about testing, all those should be mentioned. Apart from that, a detailed description of test findings. And if in case there is a pathogenic variant detected, germline pathogenic variant detected, then genetic counseling is important, and that provision should be there with the lab or otherwise the clinician. So also the evaluation of relatives should be informed. So if there is no germline pathogenic or likely pathogenic variant detected, then in such a situation, if there is no family history, then it's fine. But if in case there is a strong suspicion, then one should re-look for MLPA testing. So based on family history, young age, multiple primary cancer, one should look into MLPA testing as well. Go back to the lab and ask for it. Post-test genetic counseling, if it is required. And then VUS means there is no clinical information for the patient to be, no clinical management for the patient does not change. And also there is no need to evaluate for the relatives. So integrating BRCA test results into clinical practice. Well, if you have a pathogenic suspected mutation, the recommendation is disease-associated mutation can be used for patient's clinical management and also testing the relatives. Well, VUS means that you are in a dilemma and you do not know clinical significance of it, and the patient really does not have a change in management strategy, neither do you need to check the relatives. Genetic variant polymorphism, the variant has been confirmed as not clinically relevant, and no mutation detected, as in you continue with your treatment protocol. So selection of BRCA testing laboratory, you need to actually look at these ticks, the CAP accredited and the NABL. So these, if are there, take a lot of your headache in choosing the quality of the lab. And these are some of the parameters which you can actually look: the number of tests conducted per year, how long, at least a year it should be there, the lab should be testing, turnaround time you should look at, and then the testing quality should be certified, and then whether they are doing with the NGS and MLPS methodology as well, and if they're confirming with Sanger, then it's
Dr. Piyush,
excellent.
can you conclude, please?
Sure.
It is all.
So NGS is the key methodology, and in absence of local guidelines, labs are encouraged to participate in proficiency programs. So thank you.
Thanks, Dr. Piyush. I think this was the one of the best lecture on BRCA mutations which I have heard, and most of us will benefit from this. So thanks a lot, Dr. Piyush. I think some questions are there. If anybody wants to ask any question, then, or otherwise we will take in the moderation.
Dr. Tejinder, I think there's one question from Dr. Chandra Gowda. The question is, VUS should be taken in context of family history. I think that's what he wants a comment from Dr. Piyush.
Yeah, so I also discussed this in a recent meeting with AstraZeneca, and probably Sajan, you were also there. What we concluded and what we saw, we visited the guidelines. VUS, even if the clinical history is there, probably one can watch out, but then there is no clinical implication happening. You cannot use olaparib if you have chosen the lab rightly. If you are confident on the lab, but if you have doubts on the lab, that's another thing. So that's what we concluded.
Yeah.
Thanks.
Shall I make a comment?
Yeah.
So I was supposed to do that VUS in the AstraZeneca meeting, so I couldn't do that because I was not feeling well. So VUS.
You're supposed to be there.
So US, suppose in the context, I have an example of a patient who had a VUS and strong family history of breast ovarian syndrome. Her sister had ovarian cancer, which Dr. Amit was managing. I was managing her sister who was having a breast cancer, and that mutation came as nowhere, like nowhere in the BRCA1, BRCA2 it is reported. That's what is VUS. So because of this particular strong history, we went back to the Strand lab saying that this is a strong family. This may be this mutation may be running in this family. So you take this as a novel mutation, a new BRCA1 mutation. So if there is a strong family history, this has to be reported, and the lab has to accredit this particular new mutation, saying that this has to be reported as positive. And then I got her prophylactic mastectomy and salpingo-hysterectomy, and her daughter also now tested same mutation positive. So that's the significance of VUS with a strong family history.
Yeah, actually we discussed in detail. I mean, the conclusion we could conclude was that if in case you are very sure that your lab has used a good database, ClinVar database, as well as the reporting of US is lesser, then probably you cannot do much. I mean, looked at the Solo 2 criteria, Solo 1 criteria of choosing patients. So they actually, of course, what you said is right. I mean, this is what the gut feeling is, that if in case you're seeing such a strong family history, aren't you missing on something?
Yeah.
Thanks, Dr. Piyush.
Thanks.
So now we proceed to the next session. And the next speaker is Dr. Varun Goyal. He is the Senior Consultant Medical Oncologist at Rajiv Gandhi Cancer Institute, Delhi. Is Dr. Varun?
Yes, sir.
Yeah. Dr. Varun Goyal will be taking the topic, the proven strategy for overall survival in HR positive advanced breast cancer. Please, Dr. Varun.
So, good evening, everyone. And first of all, I want to thank organizers for giving me this opportunity. So today's topic given to me is to discuss about the role of CDK4/6 inhibitors in hormone receptor positive HER2 negative advanced breast cancer patients. And I am going to emphasize on the drug ribociclib because of the latest overall survival data of the recent studies. So to begin with, just like what should be our goal of treatment for these advanced breast cancer patients? Our ultimate goal is prolonged survival while maintaining quality of life. So we can subdivide our main goal into various clinical endpoints like overall response rate, objective response rate, clinical benefit, progression-free survival, time to tumor progression, time to next chemotherapy, and quality of life. That is very important. So as a background, we can see, we all know that in the last 2 decades, with various hormonal agents, there is some improvement in the survivals, mainly progression-free survival and time to tumor progression. We have seen that there is an increment of survivals in PFS with AI when we compare with tamoxifen, and there is some further increment in survival with fulvestrant over AI. But all these agents have not shown overall survival benefit, only PFS benefit is there. Now, coming to CDK4/6 inhibitors, there are 3 drugs we have with us: ribociclib, palbociclib, and abemaciclib. So all these 3 drugs are CDK4/6 inhibitors, but there are few minor differences in all these. So we will discuss about minor differences. So there is, first of all, there is inhibition of CDK4 that mainly targets breast cancer cells, while inhibition of CDK6 may lead to hematological adverse effects. This is the main crux difference. So this ribociclib, it is more selective for CDK4 than 6, while palbociclib, it equally inhibits CDK4 and 6 both. And what about abemaciclib? It besides CDK4 and 6, it also inhibits CDK9. So there may be some different adverse effect profile, like there may be more diarrhea, vascular thromboembolism, and some increased ILD with abemaciclib use. So besides difference in selectivity of CDK4, there is one more difference, that is drug availability to penetrate and act on tumor cells. So in breast cancer cells, these are dependent on CDK4 expression and express higher level of CDK4 compared to CDK6. First difference is this. And second difference is free drug concentration. It has been shown in various phase 1 trials that ribociclib, there is 22-fold more free drug concentration inside the tumor of ribociclib in compared to palbociclib and abemaciclib. So overall, what is the indication of ribociclib? It has a wider indication because it is indicated for treatment of women with hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer, and in combination with either aromatase inhibitor or fulvestrant as an initial endocrine based therapy, or in a woman who have already received prior endocrine therapy. Like we can use it in first line or second line advanced or metastatic breast cancer patients. We can use in both pre and peri and postmenopausal women, and we can use it with either aromatase inhibitor or fulvestrant. So there is one analysis of around 4,000 patients of advanced breast cancer patients. They have shown that with the use of AI, tamoxifen, and fulvestrant, there is no significant difference in survival between 3-time cohort. There are these are some landmark trials with overall survival benefit in advanced breast cancer patients. So regarding chemotherapy, with the use of CMF, they have shown survival benefit of 12 months versus 9 months, like 3-month increment in survival. And similarly with other chemotherapy regimes, there is survival benefit. In HER2 new group, with the use of trastuzumab, pertuzumab, TDM1, all have shown survival benefit, and this survival benefit remains positive, which is possibly due to immune sensitizing effect. In TNBC group, atezolizumab have shown survival benefit and typically carryover effect shown due to immune effect. What about hormone receptor positive group? So here, till the CDK4/6 inhibitor, fulvestrant and anastrozole combination have shown survival benefit in one study, that is SWOG 0226 study, while in another study, that is FACT study, this survival benefit have not been seen. So because of these controversial data, like one positive, one negative study, these results cannot be confirmed. But with the use of ribociclib in MONALEESA 7, MONALEESA 3, and in abemaciclib MONAC 2, all these studies have shown significant improvement in survival, and positive results shown in 2 ribociclib trials and 1 abemaciclib trial, and increment on median overall survival was consistently greater than the median PFS. The overall survival positive results was not shown in Paloma 3 study, and median overall survival increment was only 3 months in Paloma 1 study. So besides this CDK4/6 inhibitor and difference in concentration, is there any immune modulation effect of this CDK4/6 inhibition? So in cancer cells, CDK4/6 inhibition upregulate MSC1 and 2 as well as tumor antigen surface, and in an retinoblastoma dependent mechanism, these usually produce interferons. These effects may activate anti-cancer activity of immune cells, and this CDK4/6 inhibition also can lead to PD-L1 upregulation. Similarly, via another mechanism, in T cells, CDK4/6 inhibition results in NF activation and production of cytokines that can enhance the activity of immune cells against cancer cells. In tumor microenvironment, CDK4/6 inhibitors stimulate anti-cancer immune responses, including a decrease in the Tregs and an increase in effector T cells. So, higher levels of immunostimulatory molecules, which is concomitant with increased level of PD-L1. So, through all these mechanisms, there may be some immune modulation effect also with these CDK4/6 inhibitors via increasing production of interferons and upregulation of PD-L1 and production decrease in Tregs. So there is one difference also, like what about palbociclib versus ribociclib? We can see that dose limiting toxicity and recommended dose was determined mainly by CDK6 inhibition. As I've told you that CDK4 is mainly for breast cancer cells, CDK6 is for hematological cells. So this CDK6 inhibition that is causing neutropenia, it is the main factor for drug limiting toxicity and recommended dose. Effect on immune cell suppression might be about the same in these two drugs, but at recommended dose for the CDK4 inhibition may be superior for ribociclib. Okay, CDK6 inhibition may be same, but CDK4 inhibition is more with ribociclib at recommended dose. Difference between abemaciclib and ribociclib. So intracellular concentration for CDK4, abemaciclib is low. It is 1/5 of ribociclib, while serum concentration for ribociclib is more. It is 8 times of abemaciclib. So this drug-limiting toxicity and recommended dose was determined by fatigue and diarrhea in abemaciclib, which might be due to off-target effect of abemaciclib. And Cmax for abemaciclib was 249 nanogram per ml, and Cmax for ribociclib was 2100 nanogram per ml. So it is around 8 times. What about treatment duration? Ribociclib treatment duration is shorter. We usually give it this in 3 weeks out of 4 weeks, so 3 weeks on, 1 week off. While abemaciclib usually given as a continuous 4-week dosing. So these are the main differences abemaciclib and ribociclib. Now coming to main phase 3 studies that have evaluated these CDK4/6 inhibitor in these hormone receptor-positive HER2 negative advanced breast cancer patients. So for ribociclib there are Mona Lisa 7 and Mona Lisa 3 study. For palbociclib, Palomar study, and abemaciclib, Monarch 2 study. So we can see here that Mona Lisa 7 have taken both pre and perimenopausal patients, and Mona Lisa 3 postmenopausal patients. Paloma for only for postmenopausal patients. So in premenopausal patient, we as such according to studies, palbociclib is not recommended. So for abemaciclib trial, all pre, peri, and postmenopausal patients have been taken. For Mona Lisa 7 trial, it was for first line. It was first line study. For Mona Lisa 7 for first and second line study. Paloma 3 for first and second, and Monarch for first and second line study. So out of all, ribociclib is the only CDK4/6 inhibitor with 3 first line indication: pre, peri, and postmenopausal, including pre and postmenopausal women, and those with visceral disease also. So especially all these Mona Lisa 7, 3, and 2 have taken visceral disease upfront. So even in visceral disease patients, they have given this Mona Lisa 7 with AI or fulvestrant across multiple endocrine partners. So Mona Lisa 7 for first line, 3 for first and second line, and 2 for first line. And in Mona Lisa 7, drug has been partnered with AI, in 3 with fulvestrant. So out of these 3 studies, 7 and 3 have reported survival outcome, and we are going to discuss about this, while 2 survival reports are awaited. So here we can see that there is statistically significant and consistently improved overall survival in different patient population with multiple combination partners. Like we can see here that in Monalgia 3, in postmenopausal women, ribociclib plus fulvestrant, median overall survival is not reached versus fulvestrant alone, that is 40 months. So here p-value is statistically significant and hazard ratio is 0.72. Similarly, in Monalgia 7, in pre and perimenopausal women, in intention to treat population, median overall survival not reached yet, while with the hormonal agent alone, that may be AI or tamoxifen, median overall survival is 40.9 months. Here also p-value is significant. Okay, ribociclib here like have been compared versus AI or tamoxifen, while ribociclib have been given only with AI, not with tamoxifen. So similarly, in intention to treat patients population, ribociclib plus AI, median overall survival have not reached versus 40.9 months. So with ribociclib, a statistically significant improvement in survival was achieved at interim analysis with a 29% risk in reduction of death, because hazard ratio is 70.71. At 42 months, we can see that survival rate was 70% with ribociclib. And similarly, with ribociclib plus AI showed a consistent overall survival benefit in intention to treat patients with a 30% risk in reduction of death. This is similar slide. Now, what about first line or in second line? So this survival benefit have been seen in both lines. So and even with fulvestrant combination. So ribociclib plus fulvestrant in first line and in second line. So survival not reached in first line versus 45 months in placebo plus fulvestrant, and in second line 40 versus 32 months. In both the graphs, we can see that there is significant difference in survival, and hazard ratio is 0.7 and 0.73. So we can see that overall survival in Monalgia 7 is not reached versus 40.7, hazard ratio is 0.699 and 30% reduction in risk of death. Similarly, in Monalgia 3, 30% reduction in risk of death, and Monalgia 3 with fulvestrant. Like in first line, 30% reduction, in second line, 27% reduction in risk of death. So across survival outcomes, ribociclib delivered superior and clinically meaningful benefit also. So besides overall survival, it doubles the progression-free survival and it delayed time to chemotherapy also. In ribociclib arm, it is 27 months versus 13.8 months. So it is doubling progression-free survival, and it is also delaying time to chemotherapy. There is one more difference, that rapid separation of curves at 8 weeks, because and that signifies early proof of efficacy. We can see here that ribociclib demonstrates rapid tumor reduction at 8 weeks. Change in tumor size, because 72% patient received ribociclib plus letrozole had tumor reduction. So that is the reason that we can use this drug even in visceral disease. So decreased target lesion size was observed in 72% patient of ribociclib arm, while in 59% patient in placebo arm. Similarly, here we can see that consistent delay in time to chemotherapy, irrespective of menopausal status. In Monalgia 7, delay in time to chemotherapy not reached versus 36.9 months, and Monalgia 3 not reached versus 29.5 months. Is there any difference regarding race? So when ribociclib have been given for Asian patients, they have experienced better outcome as compared to non-Asian patients. Out of all, in Monalgia 7, 21 patients were of Indian origin. So we have discussed about quality of life, like efficacy and survivals. What about quality of life? So this is one question, like, do you consider quality of life of patient priority when offering them therapy options? Obviously, most of us will give answer as a either as a higher priority or medium priority. So we know that high priority therapy should not just extend life, but should also give better quality of life. And for medium priority, the therapy should offer a fine balance between efficacy and quality of life. So we can see here that all these trials, Monalgia 7, 3, and 2, in various parameters of quality of life scores, which have been assessed using EORTC quality of life C30 scoring and WPI-GH scale. And various parameters used were pain scoring, overall fatigue scoring, diarrhea, nausea, vomiting, impairment of activity, and impairment of work productivity. So we can see here that in all parameters, in all these three studies, either this drug have been associated with improved parameters, improved quality of life, or as such, at least maintain quality of life. So ribociclib is the, we can summarize like that ribociclib is the only CDK4/6 inhibitor to show overall survival benefit in 2 first-line phase 3 studies. Treatment with ribociclib delayed time to chemotherapy. Only CDK4/6 inhibitor to significantly delay time to deterioration in overall quality of life in first-line setting, and there is no impact on work productivity and activity compared to placebo treatment in premenopausal patients. Now, few slides regarding toxicity. So, we should do early monitoring, which is essential to keeping patients with advanced breast cancer on course over the long term. So, what are main side effect of this ribociclib drug? So we all know that there may be increased SGPT, there may be neutropenia, myelosuppression, and there may be increased QTC prolongation. So usually in these studies, they have reported that increase in like grade 3 or more ALT, AST have been seen at around 2 months, and neutropenia and QTC prolongation have been seen at around 2 weeks. So if we monitor like vigorously and to look for these side effects and to diagnose these side effects earlier, we can resolve by appropriate management. Like this increase in ALT/AST can be resolved in around 3 weeks. Neutropenia and QTC can be resolved in around like neutropenia in around 15 days, and QTC prolongation reversible with dose interruption and or dose reduction. As such, overall, there is very low rate of QTC prolongation have been seen, that is around 3.3%, and there is no case of prostate disease pointis were reported in these patients treating with ribociclib. So early monitoring recommendation. Yes, like 1 or 2 slides. So for cycle 1, we should do baseline CBC, electrolyte, and ECG, and after that, after 1 week and after 2 weeks. In cycle 2 also, beginning of cycle and then mid cycle for CBC and LFT, and similarly in cycle 3, beginning of cycle. So there is no ECG required beyond cycle 2 unless clinically indicated, and no blood test required beyond cycle 6 unless clinically indicated. Ribociclib usually comes in the form of a 200 mg tablet, and so that is very efficient if we want to monitor like modify the dose from 200 to 400 to 600 or vice versa. Then we just can skip one tablet. So that is very patient friendly. So thank you. With this, over to you.
Dr. Endra, you are on mute. Dr.
Yeah,
Endra?
really. Yeah. Now can you hear me?
Dr. Endra, you are on mute. Hello. I think we lost Dr. Tejendra's connection. Thank you, Dr. Varun, for a wonderful presentation and also comparing all the 3 inhibitors, 4/6 inhibitors. And I think, yeah, Dr. Chandru has a question. Then we'll go ahead. Chandru, you have a question?
No.
Okay. And Dr. Tejinder, yeah, I think we lost you in between. Yeah.
So Dr. Chandru, please continue.
Thank you, Dr. Jindal, sir. So without wasting time,
Yeah, just 1 minute. There was one question. Yeah, one question from the audience. That question is for Dr. Piyush. Dr. Piyush is there in the audience. Dr. Piyush, are you there? So Chandru, if you could answer that question, the question is, what is the percentage of false positive and false negative in BRCA testing? So any guess you have of false positive and false negative?
The one which Indian, we reported the 1,000 patient, the Indian, that's the largest data in India. So that did not, reveal much of a false positive negative. So VUS is a 15%, VUS is what we call it as. We don't think as a false positive or false negative. The VUS is the one category which has 15% incidence. So it is on par with the Western data. It is reported anywhere between 15 to 30%, depending on the multiple studies.
Yeah, and false negative actually will be depending upon the type of test you're doing.
Yeah.
Like, for example, if you're doing NGS, probably you will miss around 15%. So 15% is false negative for NGS, and for that, if you're strongly suspecting a family history, go for an MLPA. So I think that should be additional test in 15% patients.
Yeah, they usually do it. If you do send it by a strand, they'll do NGS, and then they'll do an MLPA and reconfirm by Sanger sequencing. So after doing that, they'll give the report. So that's why I didn't comment on that.
Okay, I think Dr. Tendra, next session is Dr. Chandru's session. You can invite.
So now formally I invite Dr. Chandragoda for the panel discussion. He will be the moderator. Dr. Chandragoda is the senior consultant and director of the medical at Akash Hospital now. I think previously he was the heading the BL Kapoor. He is now at Akash.
So now he's no more senior consultant. We are
he's director.
He's the director.
He is a director of the Akash Hospital in medical oncology. And I would also invite the panelist, Dr. Rajat Bajaj. I think he is here. Dr. Ruchir Tandon. Dr. Washim Abbas.
Yeah, I am here.
Thanks. Dr. Amit Jain. Dr. Abhishek Yadav.
Thank you, my panelists. Thank you, sir. And I don't want to share all these slides, but it was very crowded slides, and everything has been covered by previous speakers. I would like to take you through a live case scenarios which we have treated. So I'll straight away start without any slides. And I have a 34-year-old lady, a case of metastatic CA breast. So metastatic by virtue of multiple bone mets, right massive pleural effusion. So she presented to casualty with breathlessness. Effusion is stat, ICD pleurodesis done, and limited to mets, ER positive, PR positive, and HER2 negative. Dr. Ruchir, how do you proceed? Dr. Ruchir, you are muted. You are muted.
Yeah. Can you hear me now, sir?
Yeah.
Yeah, you see, I would like to proceed with a conventional, say, from around 10 years back, I would have started on tamoxifen. But looking at the Morley-Disease 7, I would proceed with a CDK4 and 6 inhibitors with an AI. Or I would be tempted to combine with the tamoxifen because I don't want to lose that benefit.
Okay. So if given a CDK4/6 plus hormone, Wasim, what is your preferred choice in this scenario?
Yeah, I think agree. She's a metastatic ER/PR positive. Definitely, I think it is CDK4 plus tamoxifen. And actually, we have to see how bad the disease is. What is it tumor burden in her?
And she had massive pleural effusion that was taken care of by doing ICD and pleurodesis and multiple bone mets.
So definitely hormonal therapy, and one can go. There can be debate whether should we go on like with a Mona Lisa 7 or can one go with soft data of tamoxifen plus palbociclib. So what my experience is not much with the plus the AI plus ovarian suppression. My personal experience, what I have been treating patients, I have given more of a tamoxifen plus palbis.
I heard you saying combining tamoxifen with CDK4/6, especially ribo. Would you comfortable using it, or do you expect any sort of issues in that?
No, I will be comfortable because she is premenopausal, and we cannot use I think AI without ovarian suppression.
No, I'm talking about tamoxifen with CDK4/6 because Mona Lisa 7 initially.
Maybe I think I'm with the soft data. I am very comfortable, and I have been using it, and I have not found much like toxicity or anything else.
Rajat, your comments, Dr. Rajat.
So in this case, in this case, I will certainly like to use CDK4/6 inhibitors as my first choice. But then for the initial 2 weeks, 1.5 to 2 weeks, I'll be comfortable giving this patient a shot of GnRH agonist and starting the patient on tamoxifen. And once the GnRH agonists take their effect, I will be tempted to use ribociclib with non-steroidal AI. I will not be very comfortable using it with tamoxifen for the reasons that Mona Lisa 7 showed that there is a QT prolongation which is enhanced if the patient uses it with tamoxifen. So they also have now lifted their indication with tamoxifen now. So this will be my treatment of choice.
All right. So so you would like to use the ribociclib in this scenario because of the data that is available in the premenopausal setting.
Yes, it is just because of the data. I have used more of palbociclib than ribociclib. I think most of us have done that. And also we have used palbociclib in premenopausal patients, not that we haven't, and we have given it with our goserelin and leuprolide. But then now, because the data is more in favor of ribociclib, we have an overall survival data also. I think I'd like to switch to ribo now in premenopausal
In the
setting.
premenopausal. So in premenopausal, if I had to conclude, in a premenopausal, you will be, tempted to switch over to ribociclib because of the fact that it has resulted in overall survival advantage. Is that what you say?
Yes, I'm saying that.
So yeah, this lady was again she was put on Crixana. The Mona Lisa was evolving that time, almost 2 years ago, and put her on Crixana, Zoladex, and Letrozole. Now 2 years down the line, she's in complete remission. Comes in once a month for a Zolria, and then follow up in the OPD. So that's the beauty of that young lady who's HR consultant and being managed nicely, and she's her quality of her life is really good, and probably Novartis have called her for as an example case in Bombay once. So moving
And I
on.
think the other important reason for her quality of life being good must be the free ribociclib that she must be getting now.
Absolutely, yes.
Yeah.
After yeah, true. I mean, after 1 year, she's getting almost now one year plus. She's getting free of cost. True.
Yeah.
So, but disease, even the disease, while the quality initially, if he was treated with chemo initially, I just did not add that part. Paclitaxel, she could not tolerate paclitaxel. I needed response. I had CAPE, and she did not tolerate. So that way, she is very happy with this molecule. And moving on, if you have similar patient who is postmenopausal with some liver mets, what's your choice? And starting from Amit Jain. So now not us, Dr. Amit Jain. If a similar case who is postmenopausal, 60 years, what is your choice, Dr. Amit Jain? Amit is not there.
No,
Abhishek.
Amit is there. I think Amit. I don't know whether he's able to hear you because he's there. I can see him.
Yeah, I saw him once. Yeah. Abhishek Yadav.
Abhishek, I think I can't see him. Abhishek.
Rajat, you can take it. Rajat.
Sir, sorry, I missed it. You said that this patient
Similar
is
situation, postmenopausal.
Okay, and did you also talk about some visceral metastasis?
Visceral mets, no crisis.
Okay,
Yeah,
so I'll still like to. Okay, I'd still like to go ahead with the hormonal therapy, and in this case also I'd like to go for a CDK4/6 inhibitor along with a AI combination. And I'll be more comfortable using Palbase in this setting.
Okay.
Again, I understand this is debatable, but just for the more experience that I have with Palbase, slightly more comfortable in the sense that ECG monitoring is not required in the initial cycles. I'll be better off using Palbase.
Why not use fulvestrant, not EI? I mean, we have data for fulvestrant also. What's your thought on that?
So this also is another option that if you're using fulvestrant in this patient in the upfront setting, then I'll be starting it off with ribociclib. But then the other problem with using fulvestrant are you talking about single agent fulvestrant?
No. So fulvestrant plus ribociclib.
Yes. So ribociclib plus fulvestrant is certainly an option, but the problem is that if suppose this patient progresses after a few years and she comes out to be a PIK3 mutant, then I would not have any agent to combine it with alpelisib. So SOLAR-1 did not include any patients who had received fulvestrant upfront, be it with CDK4/6 or single agent fulvestrant.
But you have Bylib.
They always in my practice reserve fulvestrant for the later date if cost is not a constraint.
But you have Bylib data which is crisscross. If you have not combined, we can use AI with alpelisib.
Yes, that is the
yeah.
That is there, right.
So that has sorted out that problem. The Bylib has sorted out that problem. Dr. Ruchir, just your thoughts on that.
No, there I agree with Dr. Rajat. CDK4/6 inhibitors, especially ribociclib with AI, letrozole. That would be my choice of keeping fulvestrant later for the use, possibly that PI3KCA mutations.
Wasim, any comparison amongst the three CDK4/6 inhibitors? So what do you prefer? Or if you have what all the experience with have with the other CDK4/6?
See, definitely, and our experience, my experience personally is with the palbociclib, which I have used a lot. And now recently I have started using ribociclib, and as far as I have not like encountered any cardiac toxicity, and I think tolerance has been fine. I don't think it is that bad a drug. And I think there was when it started, there was that it has more neutropenias and it has some QT prolongation. And although we do ECG, we have to be very careful when we give ribociclib. I do ECGs, I do look at QT interval, and what we have seen that what I have read that you have to be very careful for the initial 1 month, 15 days to 1 month, I think. So I do ECG at 15 days and at 30 days check the QT, and if it is fine, then I think I don't do ECG then at all.
So are you comfortable using
ribociclib? I have not used at all.
If somebody is more than 75, what we would like to use? 75 year metastatic CA breast, ER positive or negative?
Yeah, I think 20 we haven't done no increase in cardiotoxicity actually. Okay. So I think it does not result in more cardiotoxicity in a 75-year-old patient. I think the mechanism is different why it results in a cardiotoxicity. So I think age is not a barrier for using the ribociclib.
Okay. So
I just like to make a comment here, Chandru. Yeah.
Sajjan. Yeah.
So my experience, I think actually I've been almost using only ribociclib in my practice, because one is the cost, and then I found this drug to be really good for my patients. And as with regard to many of my colleagues are using palbociclib, but when I have used in a large number of patients, I found it to be reasonably safe. In fact, apart from like one patient I had among the more than 100 patients I have been treating, only one patient had QTc prolongation. That also reversed when I stopped the drug. And neutropenia was much more manageable, and definitely side effects are lesser compared to palbociclib, which I was using previously. And if you just see the overall cost also for many patients who are not on any panel or are not being supported from outside, in long term it is found to be more cost effective.
I agree, Sanjay. I think the titration is also is very easy because of the 200 tablets, and then the cost effectively comes down if you have to titrate down the dosages. So I think I completely agree with Sajjan in that regard. And abemaciclib, anybody has experience? We have used because we are part of Monarch 2 and 3. So it's a drug which I don't think so should discuss much, because I don't think so it's going to be successful. It's my opinion, completely my opinion, because it is a very, the patients which we have seen having a lot of diarrhea. Almost one patient was telling me that I have to carry a bucket a whole day to counteract diarrhea. So that kind of a diarrhea is there with abemaciclib, and weird upper abdominal pain. And that was the second thing which was, almost intolerable. So I think these two, as for the tolerance of these two CDK4/6 have been concerned, palbo and ribo goes hand in hand, and the individual preferences, as Sajjan was pointing out, plays upper hand in premenopausal with the ribociclib. Postmenopausal, you have to either of the two to select. So depending on what your preference and the tolerance is. I think with this, I thank my panelists, and I'll wind my session. Thank you, Sajjan, and thank the Novartis.
Thank you.
Thank you, Dr. Tejendra.
Yeah. Please unmute yourself, please. Boss, unmute yourself.
Thank you, Dr. Chandragoda and other panelists. And now I invite Dr. Sajjan to kindly take over.
Okay. Thank you all. Thank you the faculty and the esteemed panelists, and all of you for really joining us for this evening session today. It has been a very proud privilege for all of us here conducting this meeting. If you have any questions, please write them in the chat box so that we could actually discuss. Dr. Chandru, I think one more question for you. So with this OS data with the ribociclib, so what you really feel is like because other CDK4/6 inhibitors were not able to get an OS benefit. So what does that reflect? Is it the trial design which is the difference?
Yeah, I completely agree. The one is the trial design, and we have seen almost 30,000+ patients with a network meta-analysis of a combined CDK4/6 with AIs have been done, and that has shown a combined OS benefit. So in that context, you have to take that particular thing, not an individual trial data. So there's definitely likenesses which we not discuss at this point of time. And with that context, I say that you can use either of them, depending on that network meta-analysis which has revealed survival advantage in any CDK4/6 for that.
So I think there are just two concluding things which I would like to say. So with BRCA1 and 2 being important biomarkers, not only in ovary, but now emerging in breast and in pancreatic cancer and also in prostate cancer, we'll have more role for BRCA inhibitors or PARP inhibitors. And in the near future, we'll have trials showing good results into this population, and probably some more drugs also coming in this area. Also, with more choices for your CDK4/6 inhibitor, I think we all will have some personal preferences, but I think we have to choose them wisely. And Dr. Amit, thank you so much for logging in.
At the end, is appeared.
One last question. Just very interesting. I have a patient, CA breast. Now, after 2 years, she relapsed in pain. So now we have removed that. There was a one lesion in occipital area, which was removed by neurosurgeon. So my question is, like, how do we go from here? Should we start on? She was on, I think, AI. She was on letrozole. Should we start on fulvestrant plus abemaciclib, or how should we proceed from here? Because we know that.
Yeah, abema is the only thing which can cross the blood-brain barrier. So in that regard, I agree with you. The simple notion that the ER+HR+ positive HER2 negative doesn't much go to brain. You know, it's very, very rare.
Yeah, I agree. No, she's ER+HR+ positive again.
Very high. Yeah. Very rarely this scenario is entertained. And then in that context, I agree with you. Go ahead with abemaciclib. You have that is the only drug which can cross blood-brain barrier.
Okay, so I thought I will discuss here. So.
Yeah, but start with the 200 mg. Don't go to 300. 300 you will have horrendous thing. So start with the 200, then hike it up to 50. Don't climb down, just climb up.
Okay.
Yeah.
Okay. Thank you.
Dr. Amit, do you have any questions as a part of panel? Do you have anything which you would
like to? I have one question. I had a patient who was on ribociclib plus letrozole for 1 year. And just after 1 year, there was some break, and for 15-20 days, and then the disease progressed. So, can we start ribociclib again, or do we have to switch to something else?
Dr. Amit, I think you need to check for PI3K mutation immediately.
Yeah, because it's only 11 months actually on ribociclib, and because the treatment was stopped, and then the progression was there. The progression was not there on when the patient was on treatment.
See, anyway, you need to switch over to fulvestrant at some point of time.
Agree. There's a lot of debate. Like, agree with you. Should we do PIK3CA mutation, or should we switch on to fulvestrant? Right? That is the question.
Yeah. Or we can continue with ribociclib.
Depend how long she has discontinued, how long she has been off drugs, of this drug.
Discontinued for 2 weeks.
I don't think so. It's the 2 week that might result in, because see, if you see median time to response to ribociclib and even palbociclib is like 6 weeks, right? So I think be progressing.
Yeah, it was a bit unusual.
Progressing on drug. It's a very bit unusual, and definitely the data for PIK3CA, and I think that it's. What do you think, like fulvestrant or PIK3CA?
I think here within Sajjan, go ahead. Sajjan,
no. This is Richard.
Richard.
You see, I wanted to make a point that a disease which has just recurred by stopping ribociclib for 2 weeks is suggestive of aggressive tumor biology. So this is mostly seen in around say 40% of the patients who are having PIK3CA mutations.
As per the SOLAR trial. Because the patient is already on almost 11 months of ribociclib. So just talking for 2 weeks, I don't think so will make such a difference. I mean, that's according to me.
That I agree.
So if the evaluation was done almost 3 months ago, and then now there is a progression. That's a significant progression, even if there's a
Yes.
two weeks discontinuation.
Quite right.
So if the evaluation was 15 days down the line and now it's progression, then it's very unlikely that he is evaluated then now. So then you take it as a progression. Definitely pick 3 is a way to go. That's then a proof of concept. So you do a pick 3 which is positive in almost half these patients.
Yes.
So and then take on from there.
Yeah.
Yeah, I think Dr. Amit, you made a very valid point of bringing in pick 3, especially in early non-responders, and that should be a part of our strategy. Whenever we are having patient who is not responding, that went to a first line CDK4 inhibitor with AI. These should be checked for pick 3 mutations. And then Ruchir also praised in and you pointed out very validly that they should be checked for pick 3. And if pick 3 is there, definitely we have to add a pick 3 inhibitor because that really makes a lot of difference into these.
Oh,
So
great.
yeah, thank you so much, Dr. Chandru. I think very great discussion without even presentation, and that's the beauty of this presentation. We had live case discussion, and I think we discussed 2-3 cases. Wasim also put in one case, Dr. Amit also put in. So actually, a lot of work case discussion happened, and I thank you all for this very, I would say, interactive panel discussion. And the last session was actually was supposed to be taken by me on management of COVID-19, but I don't think there's any need for this session because all of us are doing it day in and day out. Now, we all know now that how to tackle COVID, and also to take care of our patients well. So with this, I will first like to thank all the faculty members and all our audience for spending their time here with us. And I think it has been very useful for the people who have attended this meeting with us. And also, I'd like to extend my thanks to the organizers for today's meet, Novartis as well as AstraZeneca, for bringing such valuable speakers to this evening meeting here and all expert panelists here. Thanks a lot. And especially thank you, Dr. Tejendra Singh, to be part of this organizing meeting. And then it's been wonderful with you, boss.
Thanks.
Thank you.
Thank you. Thank you, sir. Thank you.
Have a good night and have a great dinner and stay safe.
Bye.
Bye. Bye.
इस पे आ रहा था अच्छे से इस पे तो सुनाई नहीं दे रहा था उस दिन शायद टीम्स पे 3 और एक जूम पे भी इस पे तो दोनों पे सही आ रही है सर
Arun, are we offline now?
Yes, sir. We are.